present to you. So as Matt said, so I'm a consultant anaesthetist from down the road, but actually my interest in shared decision making actually started probably local to where you are when I was a UCL POM fellow. That was in 2015. So just to say, that's the kind of trajectory that 1 year can have. So this all started with a coffee conversation with Dave Walker in the coffee room on the bridge. So where he asked me to write 200 words on shared decision making, and then look what happened.
As all good things start with these sort of chance meetings with Dave or Ramai, isn't it?
Yeah. So yeah, thanks. It's a real pleasure to be back almost. So thanks for the invite. So like I said, I'm a consultant anaesthetist down the road, and I'm sure none of you need any introduction to Guy's and St Thomas's, kind of, you know, much like UCLH, we're across the river, and I'm part of this is, you know, really hope that over time that we build some bridges across that river. I have really fond memories of UCLH. I think, you know, CPOM is amazing. I'm also part of CPOM in the kind of in my academic role. So yeah, like I think, you know, this is a prime opportunity, especially given the context of the pandemic and, you know, trying to be more collaborative. So I wanted to start with a little bit of a personal story. So as some of you may or may not know, so I am Sri Lankan in origin. I also have the misfortune of having family in Hawaii. So it's not that uncommon that I'm on a waterfall hike in one of those exotic locations. But unfortunately, the pandemic had different plans. So I found myself on a waterfall hike in West Wales, not quite as tropical, but still, you know, it was the best that we can do given the situation. Unfortunately, it ended up slightly differently to how I planned. So I got very close to the waterfall, missed my footing, went out onto my dominant outstretched hand. And as you may see here, sustained an avulsion fracture. And I can now tell you that hand injuries hurt a lot. I had a number of kind of discussions. Obviously, we were really lucky. I had, you know, 2 plastic surgeons who I was able to kind of refer to, and I essentially had several options. I could have had surgery. I could have intensive physiotherapy, or the other option was to do nothing at all. Now, I think, you know, I was strongly advised by one kind of hospital to go with the surgical option. So they were almost ready to list me for a trauma list 48 hours afterwards. I have to tell you, this is a minor injury, but, you know, I couldn't have signed the informed consent form when I was seen in kind of the extension of the emergency department. I don't think I had enough processing time. You know, I just didn't feel lucky. I didn't feel ready. And actually, one of the aspects was that I was able and enabled and empowered to actually say to that plastic colleague over time. They said, you know, you've got a 2-week window. I was lucky to get a second opinion, and the second opinion said intensive physiotherapy. So I was in a bit of a quandary, did a bit of a Google search, PubMed search, trying to decide outcomes. But what actually helped me decide was, you know, thinking about my functional recovery. Now, it seems the surgery was very much based on the fact that my avulsion piece was probably going to lead to malunion. So it was probably going to lead to an ugly X-ray. However, functionally, I was going to get better outcomes from physiotherapy. I'm very left-handed, so I'm left-hand dominant. I do almost everything with my left hand. Do not ask me to do anything with my right hand. And obviously we have you know, as an anaesthetist, the laryngoscope is a left-handed instrument. I'm also a yoga enthusiast, and that means putting a lot of weight through both hands. And I play a South Indian Carnatic musical instrument. So I had to decide what mattered to me, and I decided that I don't mind what my X-ray looks like, but as long as I had good functional outcomes, that was what was important. So I went with intensive physiotherapy. So really kind of who decides? Well, this was the subject of an anaesthesia review article that I was lucky to co-author with my colleague Jude Partridge, who's a geriatrician here at Guy's and St Thomas's, and Carrie McEwen, who's a surgeon. And I think we all have different perspective on how we do shared decision-making. And this was particularly in the older surgical patient, but some of the lessons I hope are relevant to the wider remit. So there's obviously aspects such as how we risk assess, how we risk stratify, how we look for opportunities to optimize that risk. So prehabilitation is one aspect that's really come into vogue in the context of the pandemic. But there's also that kind of softer skills of how do you actually understand what's important to a patient? How do you have that, sometimes quite brave conversation to try and decide? And, Matt and I were speaking. So today I'm in high risk clinic and I've got a gentleman with post-polio syndrome, quite functionally debilitated, who's been listed for a total knee replacement. So that's going to be quite a tricky conversation for me to have with the patient to try and understand what's important. And we have a spectrum of choice. So obviously with my hand, I could have gone with paternalism. I could have gone with that trauma list 48 hours afterwards, but there was something inside me that, didn't feel comfortable with that choice. And I was lucky that I was able to speak my views, but not all patients feel the same. There's obviously consumer choice. So I could have done a PubMed search, which actually essentially said there was no difference in, functional outcomes, whether I went with surgery or physiotherapy. But what I really wanted is a shared approach. So I wanted the expertise of the plastic surgeons, but I wanted to decide what was important to me. So there's many definitions of shared decision-making, and this is the one that I still use and have used, for the last kind of five or so years. It's from a King's Fund report, and essentially it talks about clinicians and patients working together, and it's based on the best clinical evidence. So shared decision-making doesn't strip you of your professional autonomy, and it asks you to present your clinical expertise, but it says, think about the patient and think about what's important to them. And in all this, you need a decision support or counselling. So for example, the patient I'm going to see in high-risk clinic later today, I need a way to communicate that to all relevant teams, but importantly, also back to the patient and the family. So why deliver shared decision-making? So I've become quite an enthusiast of the value-based healthcare concept. This is that, anything we do within healthcare must support quality, it must support outcome, obviously, and it must also support kind of efficiency or kind of drives in cost. One aspect of VBH is the quadruple aim, and this is very much the way I've been presenting shared decision-making, particularly within my own trust, and we've gained some traction with that. So with respect to the quadruple aim, shared decision-making, first of all, improves patient experience. Now we know this from CQC reports. So every year the CQC asks all hospitals, all hospital patients essentially, how involved were you in your decisions? And as you can see, over the last kind of 10 or so years, about 50 to 60% of patients have said that they were definitely involved in their decisions, but actually there's a huge room for improvement. Now, I would caveat this, I think patient expectations have risen, but I still think, this shows that patients want to be more involved in their care. So the classic kind of argument against SDM is patients don't want it, and I don't think that's true. It improves patients' outcome. Now, Cochrane actually reviews shared decision-making on a relatively regular basis. The last one was in 2017. And shared decision-making improves patient confidence, improves their outcome, improves their compliance to therapy, and it also improves their engagement. But actually, really interestingly, in actually kind of the last 3 or 4 Cochrane reviews, is that it actually reduces the intervention rate in major surgery. And that's always highlighted. And in the last Cochrane, that was as much as 16%. Now, I think this is really important given the context that we find ourselves in, where we're trying to move forward with elective recovery, that, we need to really ensure now more than ever that we're actually operating on the correct people, where it actually aligns with their kind of therapeutic values. It improves workforce experience. Now, this is something that I feel quite passionate about, again, given the context that we're now entering a phase where our workforce is somewhat exhausted, we're tired, we're fatigued. I really got into shared decision-making, as you said, as I mentioned earlier. It was actually a coffee chat with Dave Walker on the bridge about 5 years ago as a POM fellow. But also kind of reflecting on my experiences as an anaesthetic registrar. Quite often I felt on the morning of surgery that I felt really uncomfortable with proceeding sometimes with procedures, particularly high-risk procedures, because I didn't think it was in the patient's best interest, or at least I didn't feel that they were informed. Subsequently, I've learned that there's a concept known as moral injury, and that very much encompasses that feeling that I was feeling. And the more I speak to kind of anaesthetic colleagues or perioperative colleagues, we all have this. And I think it's really important that we acknowledge the burden that we take on, particularly when anaesthetizing high-risk patients. This is something that we speak about quite extensively in the Anaesthesia article. Cost effective. Now, I'd like to stand here and say that shared decision making is cost effective. I think we don't really know. I think it makes sense that with some upfront costings, that actually it reduces your costs further down, and that's probably through increased efficiency. But I can't categorically say that. I don't think the health economic argument has concluded on that really. So what have we done with respect to shared decision making at Guy's and St Thomas's? So I started at Guy's and St Thomas's. I'm coming up to 3 years in June. And I was really lucky. I got a huge amount of directorate support, but also trust exec support to essentially start a Choosing Wisely initiative here at Guy's and St Thomas's as a pilot base for the national initiative. So we've very much centered this on the Choosing Wisely aspects, which surround this acronym known as BRAN. So it's really talking about what are the benefits, what are the risks, what are the alternatives, and what if I do nothing. Now, to give some context to BRAN, so BRAN really came from the National Steering Group for Choosing Wisely, which was led by the Academy of Medical Royal Colleges, and it actually came from our patient representative group. They said that they wanted something really simple that they can think about on the day, that they can use in a healthcare consultation to try and understand their own values, ideally before the healthcare consultation actually, because we know that 20 minutes is not enough to process all the information that we ask of patients sometimes. But also clinicians were saying that we want some simple framework. So BRAN seemed to fit this. And I think we've had a reasonable amount of success. And this is an editorial that I was lucky enough to co-author with Lee Fleischer and Mike Grocott. So what did we actually do? Like I said, so shortly after starting at Guy's and St Thomas's, I was lucky enough to meet our then Deputy Chief Exec, Eileen Sills. Now, she had a really kind of keen focus on patient experience and how we improved that. So we set up a kind of executive management committee. We set up a steering group. And what we did is that we put a call out to all clinical directorates across the trust to see who would be interested in delivering some shared decision-making pilots. Now, this was through no design, and it doesn't, I'm not sure if it was the fact that I was an anaesthetist or, kind of known within the perioperative sphere, but actually the 3 directorates that came forward were all within the perioperative sphere. I actually think there's a keen interest in shared decision-making within perioperative care. So I think it's actually a natural alignment. I was obviously very pleased. Our orthopedic surgeon said, we'd quite like to implement this within our knee pathway. Our proactive care of the older surgical patients, or it's changed to perioperative medicine for the older older person undergoing surgery, POPs came forward, and also our dermatology skin cancer MDM, and that was again around surgical options, so less extensive versus more extensive excision of skin lesions. We then also had set up a work stream around patient information and engagement, and also around a staff engagement campaign as well. We were lucky to secure some project management support, and that was through internal charity funding. And I obviously have a role at the Academy of Medical Royal Colleges, but we also linked in with NHS England and also the Wyndham Centre for Risk Communication. Eileen and I wrote kind of a locally agreed sequence, so this was all offset against a locally negotiated sequence as well. The first thing that we asked all the pilots to do was to really try and understand the baseline. Now, there's a number of shared decision-making tools out there. There's subjective tools and objective tools. I think in conclusion, you want an objective tool where you can, but they're labor and cost effective and certainly not implementable or scalable. So we went with a subjective tool, which has its limitations. We went with the SDMQ9, which is what NHS England also advised as well. So this is a paired questionnaire. One goes to the clinician or the healthcare professional seeing the patient, and one goes to the patient. And it asks 9 domains of shared decision-making, and it ranks it against a 6-point Likert scale from completely agree to completely disagree. And what we found when we piloted this across all 3 pilots, so across the orthopedic pathway, across POPs, and also across skin cancer, MDM, was fortunately or unfortunately that we seem to be doing a high level of shared decision making already. As you can see, our scores are kind of above 80 consistently. Now, I would caveat this, whilst I really hope this is because we implement shared decision making, I also think this also shows part of the challenge of shared decision making, which is measuring it. I think the SDM Q9 and QDoc are, brilliant assessments of clinicians' confidence or their perception that they're delivering shared decision making, and also of patient satisfaction. I'm not sure that it's sensitive enough to actually pick out whether high quality shared decision making is occurring already. So our conclusion is our clinicians think that we're doing it, and our patients are satisfied with their involvement in decision support. I don't think I can say much more than that. We also asked each pilot to process map their pathway. Now this, Guy's and St Thomas's, we do some quaternary and tertiary care, and some of the pathways are so complex. So I'm just going to present a very simple knee orthopedic pathway, which may be relatable to UCLH, for example. So obviously starts with the general practitioner, and they can be referred into a surgeon either through directly or through what's known as the MCAT service, which is a physiotherapy-led service. The surgeon will then decide whether the patient is okay to proceed with surgery or suitable for surgery, and then they'll go through a pre-op assessment process, which might be through our high-risk clinic, anaesthetic-led clinic, or might be through POPs. The surgeon will then make a final decision as to whether we go for surgery or not. Now, as you can see, this is relatively simple, but still very complex. And I can't emphasize enough the value of process mapping these pathways, because actually for me, particularly because actually I was still relatively new to the trust, it made it very apparent what we needed to tweak to actually support shared decision making. So what we found was actually it was anaesthetists and POPs that were doing a huge amount of the shared decision making. It was quite late in the pathway. And one of the reasons wasn't lack of will by orthopedic surgeon. It was, some of the reasoning was that actually our vetting process to actually get into a surgical clinic was actually quite poor. So the surgeons, the consultant surgeons, were using their 10-minute slots inappropriately. So actually just changing those vetting processes means that we can give them a bit more time and they can start those brand conversations. The other thing that we learned was our physiotherapists are really passionate about SDM, and actually what they can do is they can start the process early, perhaps by supporting brand or supporting that actually this is a kind of conversation that you're going to have. So not specifically giving the information about the risks and the benefits, which the surgeons very much felt was kind of held by them, but just supporting patients and letting them know that they're actually partners in this conversation. Another aspect that we did was we did a huge amount of stakeholder engagement in all the pilots. So for example, for the orthopedic pilot, we had anaesthetists there, we had surgeons there, we had POPs there, but we also had managers there, we had clinical leads, we had transformation leads. Guy's and St Thomas's is filled with transformation leads. So pretty much anyone in the pathway, we made sure that we invited, or at least gave them an opportunity to give some insights into any future pathway redesign. And some of the aspects that came out of the stakeholder engagement, which was essentially a focus group, was actually standardizing the information and agreeing kind of this common language between clinical pathways is really important. And I think it's really important because actually we each talk to the patient in a very different way. One thing that's been really apparent to me is that we look at risk completely differently. So the way a surgeon and an anaesthetist and a geriatrician, for example, might look at risk is very different. And actually we need to ensure that the patient gets consistent and common use of language. And again, that's where brand might come in. A lot of clinicians fed back that they felt pressure from external targets, such as the 18-week target. And obviously, in the context of the pandemic, we feel that even more. Another aspect was that a greater amount of prep and expectation management for patients was needed far upstream. So actually trying to start that shared decision-making process when a patient hits secondary care is too little too late, and we all know that. It's something that we've been saying for many, many years. So I'll go on to what we've done about that as well. From a patient engagement aspect, we did 57 semi-structured interviews, again, around the concept of brand and what they would want for shared decision-making within perioperative care. And some of the feedback, so less so the quantitative, I think the qualitative is actually really useful when reviewing these questionnaires and the interviews. So we still found this power imbalance. So a lot of patients told us, you know, if the clinician or healthcare professional asks us about shared decision making, then yes, we want to have that conversation, but actually it's really difficult as a patient to bring that up ourselves. That actually patients also wanted a great amount of preparation and information leaflets would be useful ahead of time. But also, however much they prepare, they're still going to be anxious and nervous on the day, and actually they wanted prompts on the day. So after a huge amount of kind of engagement exercises, one of the aspects that came out of these initial pilots is that we developed a brand leaflet, so a patient-facing leaflet, and this is just the back of it, it's a try leaflet. And it's really to try and start that SDM or brand process quite early in the pathway. So these now go out with clinic letters, so with the kind of invitation to the initial clinics in all 3 of the pilots. And we're just kind of reviewing the efficacy of this, or really if we need to tweak them. But it's really to give patients the space to start to think about what are our benefits, what's the risks, what are the alternatives, and what if I do nothing. Now, Guy's and St. Thomas's digital information is interesting to navigate, let's just say. So these were initially paper leaflets, and one of the aspects that we're really looking to do now is actually change this into something that's much more integrated, much more digitally supported. Obviously, this is not appropriate post the pandemic. We've been delivering education and training, shared decision-making workshops, and these were based on national workshops that we did through the college and then the RCOA POM program. And they're based on the MAGIC model, so making good decisions in collaboration. We've been really lucky with our keynote speakers. So we've had Alf Collins. Our last workshop, we had Nadine Montgomery. We've also had Angela Bader come and speak from Harvard. The concept of these workshops is that we have a kind of short plenary, but actually it's very interactive. So we do, we view kind of videos of a bad and a good consultation, but then we actually spend a lot of the time doing role plays. And what we found in our workshops, so this is 70 participants, and the participants is really interesting. The first workshop we did in March of 2019. And initially, the predominant audience was anaesthetists. So of the 30, we probably had 2 people from other specialties, but actually it's much more balanced. So the last workshop we did, we had close to 8 surgeons. We've had kind of physiotherapists, specialist nurses. We've had POPs involved. So it's actually really interesting to see. Actually, it's much more balanced. And I do think the interest is out there. The other aspect about these workshops is actually it's a really good stakeholder engagement exercise, because they're free workshops. They're time for people to have some CPD. They're RCOA accredited. And it's been really interesting because I've been observing how shared decision making is much more kind of accepted as something that we need to develop since starting these workshops. And this is across the trust. And we see kind of improvements in confidence in several domains of shared decision making as a result of these workshops. But again, I'm quite an enthusiast of the qualitative feedback that we get. And one aspect that the workshops have really shown us is that Johari's window model, that you don't know what you don't know. So I've had, people say, I really didn't know why I was going to those workshops. I do shared decision making already. I don't really need to be trained. And then they have this complete light bulb moment in the workshop where they actually realize the gap between their delivered practice and what their perceived practice is. We've supported the workshops with e-learning. So this is e-learning, and this was a collaborative module that we did. This was between the Winton Centre for Risk and Evidence Communication, the Australian Commission for Health and Quality Safety, and also the Academy of Medical Royal Colleges. And we've just updated these so that they take into light the recent GMC informed consent guidance. They're open access, anyone can create a login for them. They take 2 hours. and we've actually published on the kind of initial review. We've actually published on the initial review of our first 400 or so participants in the BMJ, so I can send that link if any of you want it. So a huge amount of work in those kind of 12 months of the pilot. We did all the work. We were about to report to NHSE, and then obviously a certain pandemic and virus came. So we've got the lessons, and we're certainly going to take that forward. But unfortunately, we didn't get the sequin, which was actually mounted as 500,000. So that was a bit of a disappointment, and that was going to support forward work with SDM. So when COVID came along, we really had to rethink things. And obviously, a lot of us have had to change our perioperative pathways quite considerably in the context of COVID. And whilst SDM is definitely a component, it's definitely made things more interesting. But I'd actually say overall, I think we're moving towards a much more patient-centered model. So we've become real advocates of the concept of turning waiting lists into preparation lists. And some of you will know this kind of BJA editorial that was published towards the end of last year or early this year. So we've obviously had to move towards digital pre-op assessment. I mean, I'm in my high-risk clinic today. We've gone with my pre-op. And I have to say, you know, this has definitely made shared decision-making more interesting, let's say. And our kind of we've got about 2,000 patients through my pre-op, is that actually by risk triaging the patients, so having low risk patients go through, which we account for 40% of Guy's and St Thomas's patients, go through quite a simplified pathway, a low touch, low tech pathway. Having video consultations with those patients that we think are higher risk. So classically would say, you know, some ASA 2, 3, 4, but obviously we also use SORT to try and classify that as well. But it's also dependent on the type of surgery that they're having as well. But it means that actually we can try and streamline and really pick out those patients that we really need to see face to face, and really invest some time in both the preparation of those consultations, but also supporting them afterwards with their ongoing shared decision making, and also having a much more collaborative approach across kind of surgery and POPs, for example. We've become advocates of prehabilitation. Now, Upper GI have been doing prehabilitation for about 18 months already, and I know prehabilitation means something very different in different contexts, but we've gone with the kind of formal supervised programs of prehabilitation. We've just had our thoracic pilot close, and that's close to 100 patients. And again, you know, we've definitely found the kind of decrease in mortality. So we think kind of our 30-day mortality close to 6%, with a national average of similar operations, so risk adjusted operations being close to 40%. That's kind of raw data, so I wouldn't kind of quote that too widely just now. We've also started a colorectal prehabilitation program as well. So we've got the first 20 through that. Now, the reason that I'm saying this is I think all these opportunities or all these teachable moments are also opportunities to support patients in SDM as well. We've also been looking at expanding our what we know as overnight intensive recovery. So for other centres, I guess it will be close to a PACU. We have a well-established overnight intensive recovery at St Thomas's. It sees close to 1,600 patients a year. This was pre-pandemic. And we unfortunately have to turn down about 10% over winter because of the pressures. Again, kind of why am I saying this? Because actually, if we're going to, you know, re-explore how we deliver preoperative care pathways and how we implement shared decision-making, there's absolutely no point if we can't support patients post-operatively. Now, I know there's a lot of talk about enhanced care models, and that certainly has a place. In our context, we've just merged with the Royal Brompton, so we do a huge amount of kind of thoracics, cardiac, for example. So very much a hybrid model is going to have to be supported at Guy's and St Thomas's. So, you know, a lot of our patients will need critical care, and that's born out of the data that we've got from our current post-op critical care services. So I just wanted to close so that I feel was a whistle-stop tour through what we've done at GSDT, but also kind of the national framing. And I definitely have become an advocate of this. There's been a huge amount of transformational change at Guy's and St Thomas's at the moment in the context of the pandemic. And I've definitely decided that, you know, with all our workforce and resource constraints, that definitely, you know, putting energy into building this new, which I hope will be much more patient-centered approach is worthwhile. So with that, I'll close.